Well, it's a big topic if you have to cover everything because stent failure can be acute and late. And we often use the word ISR for late stent failure. So for the practicalities, I've mostly concentrated on ISR rather than the acute stent failure. The stent failure acutely is usually a mechanical problem, what went wrong during the index PCI, and occasionally because the patient is not taking the tablets, and very rarely because of lack of response to antithrombotic therapy. So what is ISR? Well, the definition is more than 50% luminal loss inside and within the 5 millimeters of either side of the stent edge. But now we know very well that that's not enough for us to intervene. So we usually intervene when the patient has come in with an ACS or has clear symptoms or invasive or non-invasive assessment of the narrowing. And there's various types. Though these definitions were designed in the bare metal stent era, I think it still holds true for the drug-eluting stent era because your outcomes of re-intervention is determined by which of these four you're managing with regards to ISR. If you look into the factors influencing development of ISR, it's roughly 5 different headings, but from our side as interventionists, the things we have to look for is the mechanical factors, the same factors which can lead to acute stent failure, and the lesion characteristics. So if we are dealing with any of these lesion characteristics, we have higher chance of stent failure. So it's imperative we try to do as good as a job as we can when we do the index procedure so that we are not dealing with stent failure in the future. And finally, appropriate drugs after PCI, which has been shown to reduce further vascular events going forward. The pathophysiology is different for bare metal and DES. So if it's a bare metal stent, it's essentially an injury reaction to the vessel, and it's mostly smooth muscle cell and myofibroblasts. On the contrary, for DES, it's usually an allergic reaction or a hypersensitivity reaction, inflammatory reaction, and it's mostly neoatherosclerosis. So different pathology with regards to what we find. So this is the healing cycle, which typically takes about 90 days to finish in an average human being. And because of that, when we look into the peak timing when bare metal stent ISR presents, it's usually 3 to 6 months, and it's often diffuse. So we have various types of drug elution in various drug-eluting stents, and the commonest time of presentation of drug-eluting stent ISR is essentially 18 months to 2 years, and is often focal and neoatherosclerosis. So they do present differently. So how can we diagnose? Well, we can have some clues, just pure angiogram and stent boost and stuff. But in general, it's highly recommended that we use ultrasound or OCT, intracoronary imaging, one form or the other, to work out exactly the precise mechanism of stent failure, and then decide how we go around and evaluate it. So if we put everything together, we come up with a complex algorithm potentially. So you have, if it doesn't look very tight, physiologically assess to determine whether it needs treatment. If it looks tight, you image it and work out the exact mechanism. Is it undersized, underexpanded, whether it's neointimal proliferation, or is it neoatherosclerosis, is it a stent fracture, is it an edge dissection, etc., and then work out how to go around modifying the factor and treat it with a new stent or a drug-coated balloon. So hopefully these plays from now on. So he's the first patient who had PCI to the LAD 3.5 years back and represents with another anterior end STEMI. And this is how the coronary looks like. And when you image it, you find that's the normal part of the artery. And as you work towards your stented segment, you find increasing volume of not only neointima but also atherosclerosis. And this is now inside the stented segment, which again has a classical combination of the two. And this is proximal to the stent edge. So depending upon what we found on intravascular imaging, the plan was to predilate the lesion and prepare the vessel. So we were not entirely happy with how it looked like beyond the stented segment. So we didn't want to treat that only with a drug-coated balloon. So what we did, we put a stent more distally, put a stent proximal, so basically both edges, treated the original ISR inside the stent with the drug-coated balloon, and this is what it looked like at the end. So depending upon where was it edge restenosis or inside the stent properly, we treated it differently. Another patient who had PCI to the left main culotte stenting in 2013, represented in a different region in London in November. So 5 years, not a bad and they had found that he had severe ISR of the ostium in the proximal part of the circ, which was treated with a cutting balloon and a drug-coated balloon afterwards. But within 3 months or 4 months presented to us with the recurrence of symptoms. And this is what it looked like after predilation. So we find in the very proximal part there's a shelf of calcium from 6 o'clock to 12 o'clock, which prevents the stent from being entirely circular. And this is what it further downstream. So the mechanism of ISR was largely a new atheroma progression in an undersized stent. That's what we felt, given the vessel size distal to the stent. And a zone of fibrocalcification in the very proximal part. So what we did, we used a shock balloon to try to modify this shelf of calcium. It required 4 shocks for us to fully expand. And once we had done that, we then went forward and treated it with a new stent because it had already failed a DCB, the ostium on the circ. But in the kissing part, we used a DCB for the LAD part. And this is what it looked like. So it's always good to see whether we have managed to modify it. If you see the one on the bottom left, the stent is much more circular now. So we've managed to modify the shelf of calcium to a certain extent, at least beyond the ostium of the stent. Okay, the third patient. This is a more detailed. So had a PCI to the LAD and right in 2011, represented 6 years afterwards. With an STEMI, and the reason was a focal ISR in the middle of the RCS stent. So that was treated essentially with a scoring balloon and a 3 millimeter stent, which was post-dilated with a 3.5 balloon. And this was the final result. And there's a slight degree of hint of under-expansion where the ISR had taken place. So he unfortunately came back within a few months to us, represented again. And he had a repeat ISR exactly the same spot. And this is the reason we haven't managed to modify the background substrate which had caused the ISR in the first place. So what we did in this particular scenario is we decided to try to modify the background substrate using lasers. So we had 3 runs totaling up to 9,000 pulse, and then aggressively post-dilated or pre-dilated in this situation, you might say, with a 3.5 NC. And we put a 3.5 stent and post-dilated the 4 millimeter balloon as per the vessel size. The previous stent was a 3 stent which was stretched to a 3.5. And surprisingly has done well for 4 years. And this basically goes to show the IVUS. This is before we IVUSed, and it was after aggressive dilatation. You find a minimum stent area 6.4, but after laser and after the further layer of stent is 9. So despite having 2 layers of stent, we have successfully managed to modify the background substrate with nearly a 30% increase in the minimum stented segment. Next patient. This is a case of acute stent failure, presented with anterior STEMI. A single stent was deployed. There was a zone of under-expansion at the end of the stent, which was aggressively pre-dilated by a short balloon multiple times. And he unfortunately came back within 2 weeks. And what we find is acute stent occlusion, and we, after aspiration and dilatation, we still keep on having this feeling defect. It doesn't go. And when you image it, you find these 2 layers of stent here. But we never had 2 stents, it was just a single stent. So we had an odd appearance in keeping exactly where that was. This obviously wasn't done in the acute phase, but when you 3D reconstruct it, you essentially find that the connectors were totally sheared off, and you essentially had a stent collapse or a stent fracture, and that's the reason you can see sort of 2 layers of stent. So the management of stent fracture is obviously you have to deploy another stent, and this was the final result after deployment of the stent. Last patient. So this patient had, again, came back for a bystander RCA PCI following an acute presentation. A long length of disease with tandem lesions treated with 1 long stent. Looks quite good at the end of the procedure. Comes back after 6 months, had a focal severe ISR. And in the RAO view, you appreciate there essentially is a hinge point where this fracture has taken place. So we did try to perform an OCT, but because of NERD and very focal ISI, it's very difficult to diagnose. But this is essentially a digital subtraction angiography of the same patient in RAO view, and that shows you have a type 5 stent fracture with complete separation of the stenoid segments. So to conclude, despite moving into a DES era, we still see a fair amount of stent failure and increased PCI. This comes more frequently. The diagnostics tools are absolutely imperative to work out exactly why we have a stent failure. And we need at times to use adjunctive devices to try to modify the reason why the stent failures happen in the first place. So despite having a reasonable amount of data, it's still a very heterogeneous group, and we still need further studies to work out exactly how to manage the individual patients. Thank you.